to our next speaker, Dr. Matthew Roberts. So Matthew's a consultant urologist at Royal Brisbane and Women's Hospital. He also works at that's here in Brisbane. He works in Redcliffe Hospital as well, just north of that site, and also the Stars Hospital, which is co-located with the Royal Brisbane Hospital. He's a clinical researcher. He's a fellow at the Metro North Hospital and Health Services, and he group leads, and he's a senior lecturer at the University of Queensland, CCR. So thanks very much.
Sure. Might need Adam to unshare his screen.
Nice looking, yeah. Oh, done. Thank you. So thank you very much, Matthew, tonight for speaking with us about urological interventions in the renal tract.
Everyone see that?
Yeah, looking good.
All right. Well, thanks very much, everyone, for having me. I do profess to be a wannabe infectious diseases microbiologist, but I'm stuck with being a urologist. I do have a great interest in infections because I think urologists have a really important part to play in urinary tract infections, both from treating complications, but also prevention and risk factors and other things that we'll go into a bit later. So it's a real privilege to talk tonight, I should say. So I'm repeating a lot of what's already been said, but UTIs are extremely common, and this is from Australian NSQHSS, where it's common and accounts for a lot of hospitalizations. And as urologists, we think of them as three main entities: the recurrent simple UTIs, which are often a large outpatient burden, but can translate down the line, which I'll go into. Complicated UTIs, which has been discussed a lot, and then catheter-associated UTIs, which is probably the biggest heart sink for both of our specialties. It is a major problem. So in terms of recurrent infections, it's been on the news, and there's even a advocacy group called Chronic UTI Australia, which was established a few years ago. It's the only patient advocacy group in Australia, and it's basically advocating because of deficiencies with UTI tests leading to misdiagnosis, which upsets my microbiology colleagues, and also thinks that people are subjected to unhelpful and potentially damaging treatments and interventions, which is entirely true, because many of my colleagues, and I'm guilty of it at times as well, if there's you're not quite sure, well then do something which is better than nothing. And doctors often dismiss patients' symptoms because negative results from discredited tests falsely reassure them that there is no infection. And this, again, I'm sure most urologists are guilty of this because of negative microbiology, but positive symptoms difficult to treat. So we really need to do better. And resistance is also a real problem here. So while in this systematic review of prophylactic antibiotics for recurrent infections, it reduced recurrent infections. Up to 90% of patients develop Bactrim resistance after a month, which going back to previous talks, Bactrim is one of our important oral agents, and so we really want to try and treasure that. But this has only been done in women. There's been no older men or frail nursing home residents, which actually comprise a lot of our patient cohort. And also in the NAPS data, there's been a lot of inappropriate prescribing, which I'm sure I'm preaching to the converted tonight. And UTI is among the top 5 indications, and there's also increasing resistance seen. So from a urology aspect, this is a largely understudied issue, but there has been a couple of good studies. So one was what they called the Global Prevalence of Infection in Urology study, which was 856 urology units comprising 27,000 patients. And it was a point prevalence study. And basically of those patients included, 12% were from urosepsis, and there were high resistance rates, including 45% of multi-drug resistant pathogens. And this urosepsis rate increased over 10 years from 15 to 25%. And so they looked at this in more detail using the SERPIN study, and I believe this is under submission at the moment, but it has been presented at our European meeting, where they looked at prospective longitudinal data collection and found that the 30-day mortality was about 3%, and clinical failure is quite high. And the determinants here, aside from the obvious ones of age, comorbidities and acute illness, is previous UTI burden and catheter burden. And the risk factors, as alluded to in the first talk tonight, geographic location and travel, but also previous admissions, antibiotics, and catheter burden. So we're seeing similar themes between different studies. So where do we fit in? Well, I personally think we're central to this because we understand the pathogenesis of lower urinary tract and upper tract dysfunction, the anatomy of such, and then we have a little bit of an understanding of pathogenesis of infection and how the two interrelate and the potential treatment options, but we're really not at all experts in the specifics of treatments such as the appropriate agents, contraindications, and that's where we really lean on most of you. But I do think we are the masters of source control, and my intensive care colleagues say they love a good urosepsis because often we can get in, do something, and they get sick very quickly. So that makes us feel good. And many people think that urologists, we play with robots and we put cystoscopes in people and that's all we do. When in actual fact, I think most of our benefits that we can provide are with a catheter or aspiration and really just good counselling and education. For recurrent UTIs, avoiding of risk factors, non-antimicrobial measures really are our priority. And then if we have to, antimicrobial prophylaxis and self-catheterization if there's residual urine, and we really want to limit catheterization and duration. In urosepsis, source control, obviously as soon as possible, and antimicrobial stewardship. And again, I'm preaching to the converted here about antimicrobial stewardship, but these points here are cut and paste from our European urology guidelines. So this is what we try to do. So to move on and try and bring something new, I thought I'd do some case studies of some interesting people I've seen over the past 18 months. So 71-year-old lady, recurrent UTIs, one febrile UTI earlier in the year, history of hypertension, renal stones, boring ultrasound, all pan-sensitive E. coli. How many of these have everyone seen here? This is very common. She had a CT, IVP, and a flexible cystoscopy, given there was risk factors for malignancy, but there was nothing found initially. And we tried her while pending those HIPREX and other conservative measures. But interestingly, she had a UTI-free period of 4 months, and a cystoscopy looked like florid cystitis, and the CT-IVP actually showed a 2.5 centimetre lower pole abscess where the ultrasound was negative. So in this case, because she's so well and walking around as an outpatient, obviously has a cold abscess, we discussed her at our complex UTI multidisciplinary meeting that we've established, and we're trying her on a prolonged course of oral antibiotics initially, because trying to aspirate that is very close to the colon, and because she's so well, source control isn't a huge priority. But I'm happy to discuss any aspects of any case of these later. Another man, 75-year-old with persistent cystitis symptoms with Candida species continually grown, and his GP gave him fluconazole 50 milligrams for a month. We repeated it at our hospital and reviewed with our microbiology team, and it ended up being a glabrata that was resistant to fluconazole. And so we were really staring down the barrel that he might need a TURP, which might mean he needs amphotericin for appropriate urinary coverage. And so we tried to not use this as much as we could, and we thought, well, we'll try and treat the cause and start off with Duodart, which is a dual medication of an alpha blocker and a 5-alpha reductase inhibitor to improve his lower urinary tract function. A bit of a Hail Mary because it's not actually known to reduce residual volumes or anything like that. But funnily enough, 4 months later, symptoms are much improved and he's had no recurrence. So, and he's not keen on surgery at all. So thankfully, medical management of his lower urinary tract dysfunction has actually helped clear his infection, and hopefully it won't come back for some time, if ever at all. Another chap, 42-year-old, horrible diabetic, came in with scrotal and perineal pain and was given trimethoprim, I think on spec by the GP, and maybe they didn't follow up the candida, and ended up coming into hospital as the symptoms were getting worse. He was otherwise well and had a non-tender DRE, so it wasn't acute prostatitis, but ended up having a prostate abscess, and that this was on a CT performed by the general medical team, and he also had a trabeculated bladder with a diverticulum. And so the traditional management of these for a long time has been transurethral resection and deroofing of these, which I've tried to sort of show in this video, where we sort of cut into the abscess cavity from the inside and let it drain sort of naturally through the urinary tract. But in this man, his abscess was very apical in his prostate, potentially even paraurethral. So my main concern there was that if we resect it, we might actually cause a sphincteric injury and he might end up being incontinent at the age of 42. So as a first pass, we looked at a transperineal aspiration of an abscess, which we're very familiar with through transperineal biopsy. And unfortunately didn't take any nice pictures, but we could definitely see the abscess. We saw the needle go straight into it, and we saw the abscess decompress in real time. Purulent fluid was taken, sent, and came back as candida. So he was given fluconazole for 4 weeks, and a repeat CT shows no reaccumulation. But for this chap, he, as a terrible diabetic with an open bladder neck, unlikely to be obstruction, he's got some underlying voiding dysfunction that we need to try and get on top of. So we're looking at an MRI spine and urodynamics because he has some form of a neurogenic bladder. And it possibly might be diabetic neuropathy, but at the age of 42, already getting this, he's got a long innings ahead of him, so that the more that we can get on top of this earlier, the better for him. This one was a young lady who's a heavy drinker and had a long history of chronic pancreatitis and had a drainage of a pancreatic pseudocyst 3 weeks prior, and turned up with a worsening abdominal pain and had a CT scan which showed this multiloculated perinephric collection, which our usual thing is, well, we'll try a perc drainage, and the first of these showed MRSA. She still, I think, had the odd fever here and there. The CRP and white cells weren't improving as much as hoped. So she underwent a second perc drainage 10 days later. It grew the same thing. And this sort of fistulodrenogram shows that, the extent of the collections are really far and wide, but it's, it can only get into so many loculations. And so we discussed her with our colleagues at the MDT, and really her only option would be conservative management and prolonged medical therapy or removal of that kidney. So we tried prolonged antibiotics to start with, and thankfully Bactrim DS was appropriate. And I think this was 6 weeks later, there's essentially resolution of that. So it's amazing what conservative therapy can do, and medical therapy. And, I was more probably for her in the nephrectomy camp because I thought she needed source control, but the older, wiser urologist said, give conservative management a long go first, and looks like they were right. So if you hear us push back on, immense source control, it's usually because of cases like this. And lastly, I don't know how I'm doing for time, I might be too short, but this 43-year-old man had a MRSA UTI a month prior, which was Staph aureus, and he was given 5 days of Bactrim, so undertreated. He had long history of IV drug use, Hep C positive again. I'm sure we've all seen these people. And he presented 3 days prior to the this index admission with fevers, frequency, and orcalgia. But the urine was essentially negative, and he discharged against medical advice and was given 10 days of Cipro on spec for presumed sort of epidural morchitis, complicated UTI. He then presented 3 days after that part with worsening flank pain, but actually had no fevers at that point and was hemodynamically stable. The CT showed a 3 centimetre renal abscess, or that was what was reported, and he was empirically treated with vancomycin and ceftriaxone. But as he was admitted and the antimicrobial therapy continued, he got worse. He had worsening pain and fevers despite treatment. his white cells really didn't improve that much. And then repeat imaging showed that actually it had become a 6 centimetre intrarenal loculated abscess, which sticking a needle or drain into that is not going to do anything. So in his case, because it was parenchymal and progressing on conservative management, his only option was a nephrectomy, which we call a hot nephrectomy. So, you know, these are obviously the ones that make us extremely, you know, not nervous, but, you know, get the blood rushing. So we do it as a double surgeon case on a planned acute list. And the nephrectomy aspect went really well. Interestingly as well, he had a prostate abscess identified on that scan. And so we did a transperineal aspiration for him. And so interestingly, both the kidney tissue and the aspirate both showed the same bug from the disseminated infection. And he had the usual workup with echoes and that sort of thing. I can't remember the outcome from that. So based on that aspirate, he had 2 weeks of vancomycin IV and then 2 weeks of clindamycin. A follow-up ultrasound showed that it was 1 centimetre from, I think it was 3, on MRI. And just I've sort of zoomed these to be equivalent scale. And so this was the initial size and this was the resolving one. And again, in him at a 42-year-old man, risk of deroofing and potential incontinence, ejaculatory dysfunction and others could be catastrophic. So, you know, an aspirate. So I've now really become a fan of aspirating first and then draining if it reaccumulates, because often aspirate is enough to get people out of trouble in the first instance. I'm sorry, I can't remember if he had this vancomycin as an OPAT or HITH type arrangement, but that's why I finished on this case, because it's the most relevant to that. So I just want to thank you again for having me to speak. And I've just put up a picture here of Sumi Britton, who is my co-lead of our complex infection service at, or urology infection service at the Royal Brisbane, and has been a tremendous support in us setting it up and working through these difficult cases. And we now have quite a large team help us with them. And it's supported by both Metro North and University of Queensland. And so once the Queensland government allows you all, I'd encourage you to come visit sunny Brisbane. Thank you.
Thanks very much, Matthew. That was a really good talk. Really impressive to see some of the techniques you and your colleagues can use, and obviously great value in having a MDT set up where you can discuss that amongst your colleagues.